and see where we go from there. I think one of the topics here that comes up is screening. You know, I think Mike brought that up in his slide very well. And you know, there's a lot of issues with screening. First of all, you know, the location of the pancreas way back there, like I shown you, that doesn't help. You know, compare, for example, with breast cancer. You know, to examine the breast, you have the breast right here. You can do that exam very, very good. But you know, the colon is not as accessible as the breast, right? We have the colonoscopy, and we have a precursor lesion, this polyp, and so we can target a screening test, etc. For the pancreas, we can't access the organ. We don't have a precursor lesion, and again, even if we wanted to put together a cocktail of tests to do for somebody who has the right family history, etc., we couldn't put together a number of tests that would work. So Mike, what do we have out there today? I know there's programs with combinations of CAT scans and endoscopic ultrasounds. What have you seen out there?
Right now, the Holy Grail is looking for a blood test that's going to be a marker, that's going to tell you that, you know, as I alluded to with breast cancer, you know, there was these generations and these families of women where the women were dying in their 40s. And people were like, well, why is this happening in this family? And then these brilliant researchers found this BRCA gene and said, who knows what this gene is doing, but it seems like all these people have this gene that had that. And someone found that. Someone found that needle in a haystack. And that's what we need for this disease. We need to find what is that needle in the haystack of what would tell us that these people are at risk for this, or this is why someone got this, or this predisposed you to this. Because right now we just have these imaging techniques which are, I think the best thing to think about is like who, why, and when. It's not even necessary that the imaging tests aren't as good, but who would you even do a CAT scan on? Who would you do an MRI on? Who would you do this ultrasound on? And why? When? I think are the main issues, and not knowing that.
There's a blood test which is being developed at Hopkins. You know, Hopkins has something called a National Pancreatic Database, and they've been following families where multiple generations have had pancreatic cancer there since the 1990s, perhaps even the 1980s. So they have a nice collection of patients worldwide who are at high risk. And that's where you're going to find something, is studying those particular families. They had a publication in Cancer in February about a blood test that they're developing that seems to identify patients that are at risk of developing pancreas cancer. But like any test, once you develop a test, then you have to validate it. You have to put it to the test in the real world and see if it works out, etc. So that's a very, very, very preliminary publication that just came out. Everybody is hoping for it to work out because, as Michael said, there's no polyp here. There's no calcification like you would see on mammogram. And so here is going to have to be a very subtle result, like a blood test.
The CA19-9 is not...
The CA19-9 is a tumor marker. That stands for carcinoembryonic antigen 19-9, and it's right now for screening. Martha, has no value. It has a value for following a patient's treatment. Much in the same way that you would follow a CEA for colon cancer, and so as for example, if you've had the cancer treated and you're getting the chemotherapy, it'll go down, and then let's say you say, okay, let's stop the chemotherapy for now. You follow that test, and if you see it creeping up, gives you an idea that there's something growing somewhere, so that you may have to restart the chemo, etc. But as a screening test, no value. No value. Yes, sir.
Where is most of the research being done, and what are they focusing?
The great majority of the research in pancreas cancer gets done at Hopkins. They have a lot of the funding, in all honesty, and they have the track record too, that they have investigators there who have discovered the important genes, P16, etc. for the pancreas, And so they are the ones who have the most advanced research on the pancreas. But frankly, you can't. If you talk to enough investigators, you can't buy yourself into discovery. A lot of discovery happens out of happenstance and serendipity, etc. So, there's giant laboratories at the Rockefeller Center in New York and Sloan Kettering, etc. That there's people doing research. One of them may find something out of just pure luck. You get lucky one day. But Hopkins, I would say, has the upper hand in all of the pancreas. They've traditionally have had it. Right, Mike, what you saying?
I would say, and it's unfortunate, though, the way things are funded here, that research is a very competitive environment, and that people work not together, they work in parallel to each other to be the person who is successful, and for either funding or for credit, and that people might be working on the same things in secret in the same pathway. And why would I have two teams working on the exact same thing? Why would I have them work in two different directions? So it does get frustrating like that.
I have a patient who is, she had her surgery here with me, and she is in a clinical trial about a vaccine for pancreas cancer. And she goes to Hopkins twice a year to get her blood test and her vaccine, etc. They do a CAT scan for her, etc. And she is out there she had the worst cancer, the pancreas adenocarcinoma. She's out there 6 years out. I don't know how, but I know she gets this vaccination trial done at Hopkins. That's totally like Michael says. Do we have any results for the trial published out there? No. They have that information. No one else has it. They develop the vaccine gets developed for each individual patient. So they take your own tumor and make a vaccine for you, based on your tumor. So they're super advanced, but a big advance recently? No. What people have been working mostly about is these IPMN tumors that Michael mentioned, a type of the cystic tumors, the precancerous lesions. They're studying a lot of the genetic changes that occur in those tumors. The blood test that I told you about is a big area, a big topic for research. And the third area that is getting a lot of publicity is what I mentioned about taking patients with stage 3 disease, giving them systemic treatment, chemo, radiation, shrinking down the tumor, and then taking them back to surgery. Those are the three areas that I would say get the most press right now.
Sure. The question was about research at Hartford Hospital regarding cysts. Here in New England, we have Dr. Karasik and myself, one of the other doctors who specialize in endoscopic ultrasound, have a large experience in aspirating the fluid out of these cysts. These cysts notoriously have been not very good at giving up their cells, but what they are good at giving up are when cells die within these cyst fluids, they have their genetic material that are there. And as I alluded to, a cancer is a cell that is replicating out of control. So if the cell's not going to still be there, well, it's DNA. Its genetics are going to be in there in a large quantity. And what we've done is, it's nice to have such a collaboration at one institution. A lot of people that we do the testing on have stayed for their therapy and for their surgery. So we have cyst fluid, cyst biopsy, and a surgical specimen. And what we can do is we can compare those three and try to see if in a vertical patient, are there markers that we would see that are actually, when you handle the tumor and have it, were they actually in this cyst fluid? So we're trying to find different markers on these cysts and working with a couple companies in the industry in trying to develop what are the early warning systems and early markers in these cysts. What makes one cyst special and turn into a cancer, and what makes one cyst stay there forever and then turn into a cancer, or what makes one cyst stay as a cyst forever. So we're using kind of our collection of cyst fluid and its analysis and trying to see which are warning signs or symptoms for things.
It's an important study because as we talked about, CAT scans have become very affordable. And there's no visit in the emergency room that no one escapes without a CAT scan, you know. And you keep seeing, I see in my office every week a patient that had a CAT scan done for something else. And, you know, they were having pelvic pain. They were checking for an inguinal hernia. And the next thing we know, we're working up in the pancreas. I saw just recently a gentleman who had a colonoscopy. He had a colonoscopy and they found a polyp in the rectum, way down there in the pelvis. Had a staging CAT scan and there was the cyst in the pancreas. And so, as Dr. Golioto mentions, not all the cysts have to be taken out. You know, and it's always frustrating when you do a surgery and you put the patient through a big operation to find out that it was one of the serious cystadenomas that carry no risk of cancer transformation. And so you always have the thought, like, how could I have prevented this from happening? And so this study that Michael's group is doing is exactly for that. Let's get information on the cysts that we can make a decision which cysts are we going to leave alone, which cysts do we have to follow, you know, maybe repeat the study several times and get an assessment on whether it's growing or not, etc. And which cysts do we have to act on right now and take them out as immediately. So that's what that study is about. It's very, very important. Yes?
Is pancreatic cancer related to any other kind of cancer, so that when you look at a family history, well, there's pancreatic cancer and there's colon cancer and there's whatever other kind of cancer that would make you more concerned about
There can be. If you remember one of the slides I showed, there are certain syndromes that would do that. And probably the best advice is if you're getting care in a cancer center, they have geneticists on staff. And when as doctors we think we take a family history, once you sit down with the geneticist, there's your family history. They are fine-tooth comb, and things that we didn't think were important, they ask these things, and sometimes find these relatively rare syndromes. But yeah, as the breast cancer and BRCA families are more at risk for it, this puts Jaeger's family, and even this hereditary non-polyposis colon cancer or the Lynch syndrome are at increased risk. So there are syndromes, and a lot of medicine is pattern seeking in finding things, and people who have dedicated their lives towards genetic counseling notice a lot of these patterns more, since they're especially rare, than someone who sees, you know, commonplace things.
For individuals with family history of multiple cases of pancreatic cancer, can you speak to suggestions for diet been suggested to eliminate all sugar from?
Yeah, there's no firm dietary recommendations other than a good, well-balanced, healthy diet. There's no one thing other than smoking that we can tell people not to ingest or do. The people with multiple family members, you know, if you want to talk about like an algorithm or, you know, what we would typically do with someone, when you've had a couple different generations, couple people at earlier ages, those families are thought to develop these ductal tumors or these IPMN lesions that are mucinous growths along the ductwork, and that can be very subtle. And a lot of times those are found by endoscopic ultrasound. So we have had people come for ultrasounds. Again, if this exam is normal, I don't know when your next one is. Or if this looks a little funny, well, do we watch it closer or not? Or this. So there's a lot of, the implication of a lot of these tests are, each test should be thought of as a branch point. And when you're doing a test, you should know what you want to do with the positive answer, and you should know what you want to do with the negative answer. And we don't have that information a lot of the times, you know, what the right thing to do is. But diet-wise, there's really no formal recommendation. There's always in the background this diabetic risk, or the risk of diabetes and then pancreatic cancer, very poorly understood at this point of why one would lead to the other. And a lot of these things are seen as associations, but the cause isn't known. So it's hard to steer someone like that. I don't think any American should have a high concentrated sugar diet, you know. But sure. Mm-hmm. But I'm just saying, I think a good, healthy, well-balanced diet is just advisable.
Yeah, the smoking, I think, is when you come down to it, smoking is the only risk factor that has been, you know, correlated with pancreas cancer. But they've looked at a lot of things. I want to tell you, the studies out there they've been looking at high-fat diet and its association with pancreas cancer, salt in the diet and its association with pancreatic cancer, caffeine and its association with pancreatic cancer. They've looked at people with a history of alcohol abuse who have a tendency to get this chronic pancreatitis, and whether that it leads you to pancreatic cancer. And nothing has come out in any revealing fashion but smoking. So from a diet standpoint, I would say, just like Michael said, smoking is the thing to avoid. Now, when you see new onset diabetes in like a 60, 70-year-old man, it's worth looking into that. New onset diabetes.
Things that don't fit a pattern.
That doesn't fit clinically what you usually see out there. So it's worth maybe making a CAT scan of the abdomen, etc., just for that. Make sure you're not missing, because sometimes the first presenting symptom for a pancreatic cancer is sugar intolerance, diabetes. But that's tricky. That has to be in clinical context, and that's a bit of an irresponsibility of me to make a statement like that. But just to say something, yeah.
Is there any such thing as peace of mind screening? I mean, just
Peace of mind screening. Listen, there are these programs that you see them popularized here and there, and maybe Mike can tell us, that are usually combinations of CAT scans and endoscopic ultrasounds. You see them every 6 months, every year. There is no rhyme or reason to them. More and more in the news, they comment on the radiation exposure that you give yourself from a CAT scan. And so these CAT scans today are CAT scans, that's a big radiation dose. Plus then you have the IV contrast that can a little something to your kidney here and there, etc. And so when you're going to do that for 20 years, I think the peace of mind that you might get out of something like that has too much risk with it in terms of possible damage that it causes. There's no screening test. It's a terrible thing, and that's, I think, one of the biggest challenges out there. Getting a mammogram that works for the pancreas, that's exactly what we're looking for here, because it's very frustrating, for me to sometimes go through one of these big operations that the same way I tell people, this is taxing for everybody. Just like I was mentioning here, the patient goes through this big thing. It takes a long time to recover. Sometimes us as physicians, it's like I had the operation on myself. You come out there kind of semi-injured, So, and then you see the patient in follow-up, and the cancer comes back, and it's mentally taxing, I think, for everybody. And I hear you.
What will the insurance companies cover relative to screening?
Great question. It varies greatly, insurance company to insurance company, and it varies on what it's billed, if it's a symptomatic thing or not, but it varies so greatly, each one, and so it's hard.
If you come in with the right family history, one of us can make a phone call there and talk to those one of physician-to-physician phone calls, and they usually approve it. It's the problem is not getting the test done. Is the benefit from the test? Is it accomplishing the job? Because sometimes you get a CAT scan. Some of these pancreatic masses, especially when they're small, when you want to pick them up, you don't pick them up on the CAT scan. So you get a CAT scan, and you come out happy. Oh, there's nothing there. And then it's like a false reassurance. You come back 6 months later, and it's not like that. So it's not just getting the test, it's that the test delivers on the promise. That's part of it too.
You didn't mention palliative care. Does that figure into this at all?
Absolutely. At any level and at any stage, things that it's an excellent point. The question was about palliative care, and unfortunately we didn't put it in our talk, and we very well should have, Because at any stage of disease, I think anywhere you can get any extra support, whether it's pain control, pain pharmacy, counseling, helping you deal with diagnosis, I think is an excellent, it's part of our program here, and I'm embarrassed to say we failed to mention it.
Totally. I think it's a great suggestion for next year to have something about palliative care, because for pancreatic disease, it's a lot of what we do actually. And just like I told you that you have to learn to be graceful in defeat. That's palliative care, you know, and you know, you can go through the whole thing and end up with some dignity and have a positive experience for the family, for everybody. And it's outstanding suggestion for next year.
Does marijuana help any of the symptoms?
Question was, does marijuana help any of the symptoms?
I would say yes. You know, the problem here is people always ask me the most uncomfortable of all questions as part of a palliative care, which is, how do people die with pancreatic cancer? And I know people here in the audience that we've seen this together, and it's not pretty, you know. But usually, what you would see is that somebody has a pain in the abdomen that gets worsened when they eat, so that they stop eating, they lose their appetite, and they literally waste away. It's called cancer cachexia, etc. So when your nutrition goes like that, obviously your energy leaves you. You know, you shrivel like a raisin, right? And so for marijuana here, the use of the marijuana is to stimulate the appetite and be able to keep up with the calories so that you can go on and, say, for example, if you're getting a chemotherapy, you can tolerate it, etc. Marijuana comes in, you don't have to smoke the marijuana, you know, it comes in a pill or a liquid, and one formulation is called Marinol. It has the THC, which is the component in marijuana that stimulates the appetite, but it doesn't give you the hallucinatory effects, etc. We use it clinically. I use it clinically all the time. For some people, it works better than others, obviously. It has its place, in my opinion, but it would be in a palliative type of setting, etc. Yes.
Where are the best training programs?
For surgery?
Yeah.
You know, pancreas surgery, it's an evolving question, I would say. But there are places in this country that do a lot of pancreatic cancer volume. And so, off the top of my head, the Mass General in Boston has a long tradition of pancreatic cancer surgery. But so does Sloan Kettering in New York. So does MD Anderson Cancer Center in Texas. There are places you wouldn't think of firsthand. Indiana University has a big pancreas surgery program. University of Chicago has a big pancreas surgery program. And then there are a couple places in the West Coast at UCLA. I know they have an excellent pancreas cancer surgery tradition in there also. But yeah, there's obviously I didn't mention Hopkins because I mentioned it so many times that, you know, I think it's obvious, but yes, also.
That's a great concrete answer. I would say the best training program is anywhere that has an experience, an expertise, and a passion, and is multi-sided. You know, you're going to find motivated people everywhere, and especially for endoscopy stuff, you can say, oh, you can go here, you can go there. If you find a motivated teacher that wants you to benefit and wants you to do well, and has the volume and the volume to show it, that you're gonna make the most of your learning experience, and if you're instilled with that passion, you're gonna bring it somewhere else.
Mm-hmm. They have, you know, for the high volume, the low volume centers, they usually have a cutoff number you have to do about 9 cases to be considered a high volume center, 9 cases a year. We do in excess of 35 cases a year at Hartford Hospital. That includes all the pancreas surgery. So Whipples, distal pancreatectomies, etc. So it's a very respectable experience. Are we at the level of New York City, etc.? Obviously not, but we have a good program here. The when you look at our tumor registry, how many new pancreas cancers do we see at Hartford Hospital on a yearly basis? Believe it or not, it has been the same exact number for the 10 years that Michael and I have been here. 60. 60. Now you take those 60 cases, and I told you only 20% are surgical candidate. So we're in there in less than 20 situation, right? But remember that the cysts are not considered cancer. So there's pancreas surgery that goes on there. There are benign tumors of the pancreas that are not cysts that we also remove, etc. Then we do a number of surgeries that are for chronic pancreatitis, etc. And so we carry on our 35, 40 cases of all pancreas disease. It's not just for cancer. But our number here at Hartford Hospital, how many cases do we see? 60. How many cases do we see in the whole United States? As Michael told you, 45,000. And the answer to your question, for example, why isn't any money put into pancreas cancer? Because it's just 45,000 cases a year, as opposed to how many breast cancers are a year in the country? 200,000. How many lung cancers are out there a year? 200,000. How many prostate cancers? 200,000. How many colon cancers? 150,000. And then the pancreas comes in at a low number, 45. But we spend the money where the volume is, right here. So it's so much other cancer volume out there that it leaves the pancreas deprived. Okay, so listen, thank you for coming, everybody, and have a good night, and thank you.